it is estimated that there are around 3.5 lakh to 6 lakh Americans who develop VTE each year. Patients with DVT are at a higher risk of developing pulmonary embolism. And in a multi-center study, even those patients who are admitted with DVT without evidence of pulmonary embolism, it was found that on VQ scan, around 40% of them had evidence of pulmonary embolism. So treatment of DVT is mainly involved to prevent the extension of the DVT and prevent pulmonary embolism. Management of DVT, because we have a separate lecture for DVT, I will not deal it in detail. But nowadays we are, instead of venography, the duplex ultrasound is taken for diagnosis of the DVT, and for pulmonary embolism, instead of VQ scan, we are now taking the CT scan. And it has been shown that initiation of the treatment for pulmonary embolism or DVT can reduce the mortality from 32% to 8%. So it is most preventable cause of the in-hospital mortality. Secondary prevention of DVT, it will also be, because there is a separate lecture, I will just dealing that patient with idiopathic DVT, we have to treat it for 3 to 6 months with anticoagulation, and if there is recurrence, they may require lifelong therapy. The patients with cancer and having VTE, it has been shown that if you treat with low molecular weight heparin for 3 to 6 months, they have less chances of recurrence than treating with oral anticoagulants. Unfortunately, the application of vein-cable filter has not undergone the same robust scrutiny as have other therapeutic interventions, and so our knowledge of how and when to use IVC filter is limited. So in 1968, it was created a concept of using surgical interruption of IVC to prevent pulmonary embolism. However, it was not until 1959 that botany used surgical interruption of IVC successfully. First filter was used in 1967. As we know, there are two classes of filters. One are permanent filters and one are the removable filters. Permanent are used where there is irreversible cause or patients have increased risk of pulmonary embolism lifelong. Vein-cable filters, as we know, are inserted from the two routes, mainly either from internal jugular vein or from pulmonary femoral vein. They are typically placed infrarenally, unless there is some indication for suprarenal insertion. For example, patient has renal vein thrombosis or thrombosis is extending above the renal veins. When deciding to use which filter to use, there are certain important qualities which must be taken into account, and these include inherent physical properties, clot trapping effectiveness, ease of placement, and ability to preserve blood flow in IVC. Ideally, a filter should trap most, if not all, thrombi going to the pulmonary circulation. As I have discussed, there are two types of IVC filter, permanent and temporary. There are many, 7 have been approved by FDA, and I will not be going into details of these filters. And they differ in their ability from which sheath to be used, whether they are MRI compatible or not, and the clot trapping properties. Then there are certain retrievable filters, and FDA has approved 4 types of retrievable filters, like Gunther Tully filter, G2 filter, etc. So choice of permanent versus retrievable filter. Which filter should we use? When we should use permanent filters and when we should use retrievable filter. It has been a growing trend in the United States not to remove retrievable filters once they have been placed. In a retrospective study in 2009, it was shown that only around 4% of the filters were removed after placement over a period of 3 years. So according to Society of Interventional Radiologists guidelines, the decision to place either permanent or retrievable filters should be made on anticipated requirement of duration of the protection against the clinically significant pulmonary embolism or risk of the pharmacological therapy. So this is just to show the IVC filter. What are the indications of filters? There are certain absolute indications and certain relative indications. There are 3 absolute indications of placing the IVC filters. First and foremost is contraindication to anticoagulation. Then if there is recurrent pulmonary embolism which is developing in spite of the adequate anticoagulation therapy, or if there are anticoagulation related complications. Relative contraindications include if we find that there is a free floating thrombus in the IVC, which is very likely to embolize. If there is patient has developed pulmonary embolism, there is evidence of DVT and patient has decreased cardiac reserve. So even if there is a small thrombus going into pulmonary circulation, patient will deteriorate markedly. It can be placed prophylactically, especially temporary filters in patients with severe trauma, spinal cord injury, or in patients having paraplegia. Those patients who have poor compliance for anticoagulation, they can be considered for putting an IVC filter. Or during thrombolysis, if there is a large thrombus load and we think that it can embolize into the pulmonary circulation, temporary IVC filters can be put. Contraindications for IVC filter, absolute contraindication is if we don't have any access to IVC. There are relative contraindications like if the coagulation profile is deranged, if there is total thrombus in the IVC, if there is evidence of infection, or there is small caval diameter like less than 15 mm. So should we use anticoagulation when we have used filter? To prevent thrombosis during filter insertion, anticoagulation are recommended unless contraindicated. In a retrospective study of 114 filters over 27 months, there was no difference in recurrence of pulmonary embolism, IVC thrombosis, or insertion sites thrombosis in patients with or without anticoagulation. In a prospective trial of Greenfelter et al. Of 465 IVC filters over 9 years, new DVT occurred more commonly in patients without anticoagulation. However, the pulmonary embolism and vena cava thrombosis was similar in whether you were using anticoagulants or not. Although no satisfactory differences was found, the general trend favored anticoagulation therapy for prevention of recurrent DVT in patients who are being put on IVC filter. What are the complications of IVC filters? They could be related to puncture, like if you are going from jugular site, there can be pneumothorax, there can be access site thrombosis, there can be persisting bleeding from the insertion site, or there can be pulmonary embolism. There are certain complications which are inherent to the IVC filters, and they include, there could be trauma to the IVC, there could be penetration of the cable wall by the filter legs, filter migration occurs in around 1% of the patients, 1% of the patients may develop filter fracture, infection can occur at the filter site, 30-day mortality with filters is less than 1%, and around 5% of the patients develop filter thrombosis at this filter site. So what is the efficacy of the IVC filters? There is first and the only randomized trial by Dr. etc. et al. It compared the outcome of the DVT with or without pulmonary embolism who were treated with IVC filters, with or without IVC filters. They randomized 400 patients to receive filters with anticoagulation or without anticoagulation. At 2 years follow-up, patients with filters had fewer pulmonary embolism, but more DVTs as compared to those with anticoagulation alone. At 8 years, even though total number of thromboembolic events were similar in both groups, however, those with IVC filter experienced greater incidence of symptomatic DVT, but significantly fewer symptomatic pulmonary emboli. Rate of post-thrombotic syndrome was similar. So they concluded that there is an equivalent trade-off of fewer pulmonary embolism at the cost of more DVTs in patients who were put on IVC filters. So where should we use non-permanent filters? The underlying assumption behind such system is that long-term complications such as DVT, recurrent DVT, thrombosis of the IVC, and vena cava perforation can be avoided. And the indications include pregnancy, trauma, or surgery. Temporary filters usually remain for 10 to 14 days, and then endothelization occurs. In high-risk patients, temporary filters appear to protect against pulmonary embolism and might be particularly useful as a bridge to oral anticoagulation because the existing evidence most strongly favor the IVC filter efficacy over short periods of time. So in conclusion, pulmonary embolism is one of the most preventable causes of in-hospital mortality. Anticoagulants are effective in preventing pulmonary embolism in patients with DVT. When an IVC filter, there is an equivalent trade-off of pulmonary embolism, fewer pulmonary embolism at the cost of more DVTs. The patients with IVC filters develop more DVT but fewer pulmonary embolism. As a mean of prophylaxis in high-risk patients who are being successfully treated with anticoagulants, permanent IVC filter is not an established treatment and may increase the risk of thrombus associated with morbidity and death. Absolute indications include contraindications to anticoagulation, recurrent emboli in spite of anticoagulation, and anticoagulation-related complications. In the high-risk embolic patients, however, temporary filters appear to protect against pulmonary emboli, and current guidelines suggest that anticoagulation should be used with IVC filters unless contraindicated. Thank you.
Thank you, Dr. Bharadwaj. And if there is any question from the floor, one or two questions only, short questions or comments. If there is none, we'll move to the next talk.
Just one question from Dr. Rajiv. Why is there such a low incidence of retrievable filters in that study which you quoted in US? Why is there only 11% filters which could have been retrieved were not retrieved?
Yeah, that's what we are somehow putting retrieval filter but not removing it.
Why is that?
It is the reluctance on the part of the cardiologist, not that it is not indicated. If there is a temporary chances of pulmonary emboli, if we are using retrieval filter, we should remove it. Because there is, otherwise lifelong, we are using anticoagulants for that.
I think the reason perhaps lies because the retrieving filters is not easy. It is quite cumbersome to retrieve filters. And putting in it is easier than retrieving them.
So that's why it is reluctance on the part of the cardiologist. Not.
If I can speak to that issue, one of the reasons there are few retrieved in the United States is many of them are put in for people who have there are people with closed head injuries or other things like that. They're in an ICU, usually from a vehicle accident or from some other thing. And the follow-up on those patients, once they're recovered, is poor. And so they don't come back and have the filter removed until somebody doesn't think about it, or they get off to a rehab center, and they're in a rehab center for 4 or 5 months. And by then, the window of opportunity for retrieving the filter is passed.
It's gone.
Now I personally have retrieved a couple that have been in more than 6 months, but it is not easy to do, and sometimes they won't come out. They're just, because what usually happens is the retrieval system gets stuck against the wall of the vein of the IVC, and you just can't get it loose to retrieve it. But the primary reason the retrieval rate is so low is because the people get lost to follow-up during the window of opportunity when it is to take the filter out.
Yes.
Okay. Yeah. If there aren't any further questions, Mr. Chairman, thank you very much.